Well, welcome back. I'm here today with Jennifer Schwartz, who's a clinical social worker, and she's here today to share some of her experiences with us around evidence-based practice and her use of research in the work that she does. So welcome, Jennifer.
Thank you so much.
If you could just start by explaining who you are and what kind of social work that you do, some of the different maybe clinical methods that you use, just so students can get a sense for your practice.
Of course. As Brian said, I'm Jennifer Schwartz. I am a behavioral health therapist and coordinator for a program that's based in Detroit called HELP, Health Emergency Lifeline Program, and also the new Corktown Health Center, which is an LGBTQ-focused health program, integrated care. Originally, our program was an HIV service organization, and so our demographic looks like many clients who are HIV positive, primarily adults, but maybe clients as young as 13 to 60s plus, and I would say maybe 50 to 70% clients who are Black, a large population of Latinx identified folk, some white clients in this area of Detroit, of both genders, and then many LGBT identified folks, including a large population of trans clients who have kind of sought us out specific for the kind of difference in care that our organization can offer.
So I imagine as part of a large organization,
Yes.
there's a multitude of services that are offered. Can you talk about where you fit in specifically within the services that the agency offers?
Absolutely. So the structure of the program, as I said, traditionally was this HIV care org first, a nonprofit, and this other Corktown Health Center has kind of grown out of that. And so we have a primary care clinic and then the HIV service org kind of operating in tandem. And we have a lot of crossover services, which is really nice. So I can have a client, come in and say, I'm having this challenge today, and we can send them over to primary care and have that addressed, or vice versa. If someone comes into primary care or comes in and is saying, hey, I'd like to start hormone therapy, for example, they can say, great, we can refer you over to behavioral health. Someone can assist you with a letter or a consultation, and we're able to get your need met right away, kind of from day one.
Nice.
So, yeah.
And so when you have a client in your office, is that generally therapy-based? Is it case management? What kind of direct services are you providing? Oh,
it is therapy-based, yep. We do have a case management program as well as an early intervention services program, and then some other supplementary housing, food bank, and things like that. But I both see folks individually for therapy and then also supervise some social work interns.
Okay.
Mm-hmm.
And so in your clinical practice, what's your primary approach to clinical work? Cognitive behavioral, family systems? Talk to us about that.
I would say definitely eclectic, a very eclectic approach, but I think anyone coming in to do therapy with me or anyone kind of observing our department would see a lot of threads like strong dialectical behavioral therapy, okay. Some CBT. I think we utilize a few different kind of ecological and family systems perspective models, because sometimes we do family or group therapy and also occasionally couple therapy if clients have relationship concerns. So we kind of pull from where we need, if that makes sense.
It does, yeah.
Okay.
So can you explain how you choose one of those varying models for a given kind of client presentation, and then thinking about how research might inform that? Okay. Why have you chosen those specific approaches, and has there been some link to the research that informed that decision for you?
Sure, absolutely. Well, we certainly look for links right out of the gate, depending on the diagnosis that we have assessed for a client. If I know that a certain modality of therapy shows good efficacy with clients who have a particular diagnosis, that might be just one of the kind of options that I present for a client.
For example?
So if so we're thinking, really classically, like if dialectical behavioral therapy was originally created for use with clients with personality disorders, and specifically borderline personality disorder, that might be a direction in which I look. But I also know that if I'm serving a client who has just emotional regulation challenges in general, that I might be able to pull something valuable out of that modality to serve that client. So I would present that along with some other options, provide a little psychoed on what we're looking for, kind of like what this kind of treatment might do for you, or what benefits we might see over here, and use a really client-centered, client-led approach. So that person is partnering with us all the time and making decisions about, which direction we're going to go with their treatment.
So it sounds like the research base really informs a lot of what you do. How often do you seek out new research information, or do you have a system for kind of monitoring kind of research developments? Talk us through your process for how you integrate that research.
Certainly. So I would say one of the nicest things for me about supervising interns is that they come with research, right? They're coming out of the university setting all the time with great new research. So that's one place that I'm able to access it all the time, which is a big benefit. I also cop to being kind of a nerdy individual. I really, really love the kind of academic and research component that came out of my own education in my master's, and so I continue reading and make use of all of those good alumni benefits, like library access, so I can kind of stay up on what feels salient for my clients, the population I'm working with, and other developments. So I think definitely going back to trusted sources all of the time, utilizing government guidelines and things like that. Something that I know has a huge evidence base, making sure that that myself, the other folks in the department, and the interns all are able to read research with a real critical eye, and make sure that we have a good grasp of how efficacious a particular piece of information may be, or a particular treatment might be for a client, as opposed to, this is kind of like a developing area and we're just starting to get some information and we know something might be here, but we don't actually know what a solid intervention in this direction looks like yet. So so some of it is is just weighing the robustness, I guess, of the research that's out there. But also because we serve an LGBT population, and there, in some cases, is less practice evidence out there. I don't want to say there's none, because there certainly is some, but it is not as available. And I think the primary care clinic would say, there are new standards that are coming out all the time, and even the standards that are 5 or 10 years old, we think of as being conservative or outdated, or even kind of like almost creating the barriers that they're meant to reduce. There's just new stuff coming at us all the time. So there's a new guideline that came out, I want to say from UC San Francisco recently, about LGBT and specifically trans care. I like the way they have broken down some of what they have done. So they talked about what they have an evidence base for, what they have, I want to say kind of like what is actual provider behavior around, around how medicine is used, or how behavioral interventions are used, like what it would look like in a vacuum as opposed to what we're actually doing with it at any given time. And then also things like provider consensus, like where we think this should go or where we think it could go, anyway that we see this being kind of applied in the future. And so I like that they offer those options, and I tried to think about research that way for myself as well. Both what I know, what I can kind of help a client, to imagine, like, how are we going to implement CBT in this moment, since we're not in a vacuum, and the interventions that we're talking through in session don't look exactly like it looks in your life in everyday world.
Yeah.
But then also, what does this mean? And what's important about this to the client? What's important about this with my kind of relationship and rapport with the client? So there are some things sometimes too that I think are almost intangible about therapy that makes integration of research tricky, that it is as much an art as it is a science, right?
Yeah, no, I think what you're talking about is a great example of evidence-based practice, where you take the best available research, but you consider it and you integrate it in light of your own practice experience or your own practice knowledge. Could you share a little bit with us about how you pull in or address this third piece of evidence-based practice, which is kind of cultural context or client preferences? Do you have examples for when you might have gone to the research, said, oh, I think this is good, and we're going to try and implement this, but kind of upon further reflection and talking with clients, said, we need to take this in a different direction, or that they helped you to amend it in some way?
Oh, absolutely. I mean, so I think that most evidence-based practice calls for some sort of evaluative process as a part of the therapeutic process, right? That not only do we put an intervention in place, but we also are monitoring it all the time to make sure that it's doing what we expect it to do, and not only is it doing what I expect it to do, but that the client is satisfied with it and they are getting the results out of it that they want. I think one of the strongest tools sometimes that I have with clients really truly is an apology, where I can say to that person, here's what we thought would happen. This doesn't seem to be happening. My fault. We're gonna back this up and we're gonna try it again. Either I didn't support you adequately in selecting the correct intervention for this situation, or something here is going wrong. In DBT, we believe clients can't fail at therapy, so we say, so I'm saying, I can take ownership of this. So let's reevaluate and let's go back to some other options. And so we lay out, this other kind of buffet of options. What other options do we have available? Both based on this kind of client-led approach, what feels good to you, like what are your previous experiences tell us is likely to work for you, to not interrupt your life, or for there to not be tremendous barriers that would be able to prevent you from following through on this. And then also, what can I pull in from the research that shows me that this will be effective for you? What pieces can I use for monitoring, for support, things like that.
As you reflect and kind of have this evaluation piece that's built into it, what are some of your metrics, or what are some of the things that you look for to know, I've attempted to integrate maybe a new piece of research, and I'm feeling pretty good about how things are going with that.
Sure.
What do you look for? What tells you you're on the right track?
Okay. So certainly concrete measures like Beck's indices, for example, might be one tool that we use to evaluate. We do things like client satisfaction surveys, and they are certainly not without merit. I want to know all the time, how my clients are thinking, how they're feeling. But also they tend to be biased. If clients are happy in their services and engaged and have good rapport, they tend to say you're doing a good job, even if those interventions aren't kind of gaining the sort of traction that we would want. We tend to follow up every 3 to 6 months with clients to check in on interventions. We go through and reevaluate and rewrite our treatment plans at 6 months to a year to ensure that we are making note of the progress that the client is making, or saying, we really need to change gears here because here's this goal that's been sitting on your treatment plan for 6 months and we haven't touched it. Or here's this goal that we have been working on so hard and we are not getting the outcomes that we originally designed this intervention to meet. So there are some built-in pieces like that, I think, that just are a part of like the structure kind of therapy, if that makes good sense.
Talk to us about your biggest success in terms of in terms of really looking to the literature, finding research, integrating it, and then thinking, yes, that went really as we expected, or that really produced some good results for us.
So many individual clients, experiences as being meaningful and successful for them individually. It's really hard to choose just one that stands out for me. I think sometimes that the most successful adaptations for me of evidence-based research of taking what is this complete modality and then kind of mangling it and applying it into a very specific client's life, making sure that the pieces fit. We have done some, I think, neat work around cultural humility, we would say, rather than cultural competence. All kind of aspects of the client are considered in the interventions that we do. So an example might be a client who is from North Africa, where this client had a very different experience of mental health and mental health service provision, tailoring our sessions to look more like what they would expect. So rather than like a doctor's office kind of setting, we made this almost like a social visit. So kind of like the way that my client might have gone and had tea with her auntie and talked about what was happening with her emotionally, she would come and have tea at my office. And then the resulting conversations, we were able to kind of steer in the direction of a more formal modality of therapy. But she had to get comfortable first. And so to me, like that, I can draw that back to the research and say, here we are, with our humanist perspective. She's not doing anything wrong. I'm not doing anything wrong, but we're putting people first and making sure that kind of every aspect of the care that they receive is comfortable in order for the therapy to go, in order for it to work.
So I want to circle back to something you said earlier, which was that you are a self-identified nerd and that
Yes.
you are good at monitoring the literature, or you keep an eye on research as it comes out.
I do try, yes.
So
it's important to me.
What are some tips and tricks that you might share with us about how you make that happen?
Okay. I would say getting on everybody's mailing list always.
Name names.
Oh, gosh. HRSA has great ones all the time. And you can go in and kind of tailor your preferences to which areas of care. So they have mental health and LGBT health and HIV and whatever you want. So you can just go through and check off the ones that you'd like to receive. Any colleges and universities often have really fantastic opportunities, like not always just conferences, but sometimes like in-services and like a day of learning where they'll have a really neat speaker come. And so anything, I'm going to get on their mailing list as much as I can. And I get just a ton of, mailings all of the time, a ton of emails all the time, which I kind of comb through and read what stands out to me and what doesn't. For a while I was job searching, I was looking at the National Health Service Corps stuff, and they, periodically will send, join this thing or get on this mailing list. But also there's a lot of research from the folks that participate then that goes out, just some neat mailing lists there. Going to conferences, connecting with folks that, whose work you like, and then stealing their PowerPoints, not stealing their PowerPoints, but reading through their PowerPoints and looking at all of the research that they have already investigated, because folks do a great job, citing, here's the work that I utilized. And if it's an area that I'm excited about, I can really dig in and read what they've read, and continue to make some of those same connections. So to become much better versed in a particular area in a very short time with a very kind of focused, what do I want to say? A very focused search on any given topic. The University of Michigan here that I was a part of as a master's student, remaining on that student mailing list. Sometimes it's frustrating. You get 600 emails a day, but sometimes there's gold in there. So, so staying connected in that way. And then same thing, asking my students all of the time, what are you seeing that you are getting excited about in your classes? What new research are you finding? And seeing if we can find specific ways to implement that in our programming, or asking them to do really directed work around a piece of research that they're stoked about.
Yeah.
In creating like a client intervention or something like that.
I think those are some great examples. A lot of times social workers have access to a university database or library resources as a student, and then go out into the field to practice, and there's serious constraints. There's resource limitations, time limitations. And so I think some of these suggestions around mailing lists and building networks, attending conferences, I think these are all accessible kind of ways that social workers can stay connected to the research. So thank you for sharing this.
Thank you. Of course.
All right. Well, I want to thank you so much for coming in today. Any final thoughts or any final words of wisdom to share with our students around kind of this holistic evidence-based practice?
Okay. Well, I would definitely say never stop learning, and research is a big part of that. In my career, I'm looking forward in the future to the opportunity to participate in the creation of more research. And that's one of the reasons that I'm staying kind of in a public health setting, so that some of those opportunities might become available to me career-wise, and also become available to my clients as well in the future. But as a social worker, one of the things that I think is most important to me is that research, in addition to being good and efficacious, should also be socially just. So that is one of those things, I guess, to keep in mind when you're reading research. Who does it serve? How does its implementation serve the population that you serve?
Well, thank you again. This was great. And we hope that Jen's wisdom has been beneficial for you as well.